In this session, we will have a great chance to introduce frontiers and experts in minimally invasive esophagectomy over the world, including Korea, Japan, and Western society. It is expected that the audience could enjoy various experiences from global leaders and have a valuable time to learn how they reach the top of the world level in MIE. We have four speakers at this symposium. Three speakers are going to speak over the Zoom meeting. 15-minute presentation and 5-minute discussion. I'd like to introduce only two speakers and Professor Ba read two speakers. First speaker is Professor Chang-Hyun Kang, Seoul National University Hospital, Korea. He received a degree of PhD in Seoul National University 2005 and has been a professor at Seoul National University Hospital from 2004. Dr. Kang is a well-known expert for robotic surgery in esophageal cancer, thymic tumor, and lung cancer. Today, his topic is minimally invasive esophagectomy, Korean experience. Professor Kang, please.
Thank you for the very kind introduction. And it is my great honor to have an opportunity to present this topic, the Korean experience of minimally invasive esophagectomy. I have no disclosure. And today I will talk about the three topics. The first one is esophageal cancer in South Korea. The second one is a review of the reports from South Korea about the minimally invasive surgery. And all of the reports is based on the English literature. The last one, I will briefly show our experience, our hospital's experience on minimally invasive esophagectomy as the last part. The first one is esophageal cancer in South Korea. Actually, the instance of esophageal cancer in our country is not quite high, because currently our country population has a different cultural and habitual status compared to other Asian countries. For example, in China and Japan, the esophageal cancer is very common, but however, in our country, the instance of esophageal cancer is quite low. The annual number of the newly diagnosed patients, around 2,000 patients, is quite small. As for the ranking of the cancer statistics, it is just the 16th rank of all of the cancer instances. However, although the instance is low, the overall survival of the patients are being improved continuously. In the early 1990s, the 5-year survival of the esophageal cancer was only 14%, but improved to 38% recently. The other features, the characteristics of the South Korea is we have a very strong esophageal cancer screening program. In the left side table, this is our national cancer screening program. Now is currently performed in our country. We have 6 different types of cancer screening program. For the screening of esophageal and gastric cancer, all of the general population more than 40 years old should receive their endoscopy biannually. This is a very strong factor to detect the early stage esophageal cancer. Right side, this is a paper including 16,000 cases of esophageal cancer patients. And you can see that annually the national screening program detects around 2,000 patients. And so almost 70 to 80% of esophageal cancer are now being detected by national cancer screening program. And because of the very strong screening program, we encountered many early cases of esophageal cancer patients. It is a very different features to the Western countries. In this paper, including 6,000 esophageal cancer patients, and the instance of stage 1, clinical stage 1 disease was 30%, and then an upfront surgery was performed in 31%, and adjuvant treatment were performed in 11%, which means more than 40% of the patients received surgical treatment as a first choice of treatment. However, neoadjuvant treatment was performed only in 12% of the patients. This is a very striking difference to the Western countries, because in surgical cases of Western countries, more than 60 or 70 cases of patients received neoadjuvant treatment. So we can know that upfront surgery is quite popular. And in this paper, the authors compare the outcomes between different treatment modality, and they also concluded surgical treatment was better than the definitive CCRT. However, comparing between neoadjuvant and adjuvant treatment, they could not find any difference. So this is one of the reasons why Korean esophageal surgeons favor surgical treatment more than the neoadjuvant treatment. The next topic I will present about the minimal invasive esophagectomy in South Korea. Because this topic is based on the English literature, I selected 8 hospitals, because other hospitals reported many papers in Korean literature, but I just selected the English literature papers. As you can see, there are many hospitals performing the minimal invasive surgery. However, the 5 hospitals are located in Seoul, and 2 other hospitals are located in Gyeonggi province, which is very near to the Seoul. So most of the centers who reported the minimal invasive surgery report are located in the Seoul or near the Seoul area. Only one hospital, Jeonnam National University Hospital, is located in the Jeonnam province. It's the southeast area of our country. I think that the Jeonnam University is a pioneer of minimal invasive surgery in our country. They reported their initial experience in 2009. And they started minimal invasive esophagectomy from 2004. They reported their initial experience of 28 patients, and they reported a very good early result in that paper. Interestingly, they reported 0% of leakage and a very low rate of complication rate. So we must be cautious when interpreting the early result of the innovative treatment. And most medical practice in the early stage of innovative surgical procedures, the selection bias is very strong. The surgeons usually do the new operation to the very good patient's condition. So it may be interpreted as this new innovative treatment may have better than the conventional treatment. But however, we must think about the selection bias. And the second thing we should think about is the underestimation of the complication. At the early 2000s, most esophageal cancer surgeons underestimated the real complication rate. So they usually reported a lower instance than the real practical instance rate. It's a very common phenomenon at that time. So we can find similar findings in the next presentation. The right side paper is from the Seoul National University Bundang Hospital. This is our branched hospital. And they started minimal invasive esophagectomy from 2009, and they reported their best eyeball reoperation. However, they use the open laparotomy in the abdomen. Also, in this paper, they reported 0% of leakage rate, very, very low complication rate. I think this is because of the same phenomenon. And then other hospital, the Saint Mary Hospital, located in the Seoul. And they also reported their initial experience about 58 patients with minimal invasive IVORIS operation. They also reported 1% of pneumonia rate, extremely low than our expectation. I think that this is the same phenomenon. The first long-term outcomes in South Korea was reported in 2017, and National Cancer Center, they reported their long-term survival comparing the open and thoracoscopic minimal invasive esophagectomy. They reported around 75% of the long-term survival, which was relatively good compared to historical papers. However, we must think about the stage distribution. As I mentioned previously, the early stage was very common in our country. So in this paper, the proportion of stage 1 was 66%, extremely high than the conventional papers. So we must be very cautious on the interpretation of the result. However, the main minimal invasive modality in our country is robotic esophagectomy, because major hospitals in the Seoul are using the robotic system as the primary minimal invasive surgery modality. I think the left side paper is the first paper published in our country, and the Yonsei University publishes their initial experience on robotic surgery in 2010. They started their robotic surgery program in 2006, and their early result was very, very excellent with 0% pneumonia rate. However, it is also because of the same phenomenon, the selection bias. And Samsung Hospital, they reported their initial result in 2016. But however, this is a hybrid robotic surgery. They use laparotomy in the abdomen. However, pneumonia rate and leakage rate was extremely low. I think that this phenomenon is the same, the selection bias. When applying the robotic surgery, we Korean surgeons thought about the benefit of robotic surgery. Most of the Korean surgeons agrees that the recurrent triangle lobe dissection is better than the thoracoscopic surgery in robot esophagectomy. So we were very curious about the proficiency gain and the experience gain after robotic surgery, especially when doing the recurrent triangle lobe. And so these two papers reported a similar result on the recurrent triangle lobe dissection. There's 20 or sometimes 50 cases of number are necessary to do a complete recurrent triangle lobe dissection without increasing the vocal cord palsy. These papers, the meaning of these papers is simple. Even we do use robotic surgery, it requires adequate time to get a better result using the robot system. Long-term survival on the robotic system was first reported in 2016. And our group reported our result on the long-term survival of robotic surgery, and around mid-70 or 75% of long-term survival were reported. Yonsei University also reported their long-term survival 1 year later. However, the overall survival was quite similar between two groups. And you can see in the table, the stage distribution is quite similar. Stage 1 was around 50%, so the survival outcome was quite similar between two studies. But the major centers in the Seoul adapted the robotic surgery, so currently not doing the thoracoscopic surgery actively. So nowadays, we cannot have a result comparing thoracoscopic and robotic surgery. So several centers started to report comparing an open and robotic esophagectomy. And this is examples of the studies. The left one is a paper from Asan Hospital. They reported their long-term survival comparing robotic and open surgery, and they reported comparable, similar overall survival. Right side paper is a paper from our hospital, and we also compare the outcomes robotic and open surgery. And however, the outcome result was different from Asan Hospital. Now our hospital robotic surgery shows a better long-term survival than the open surgery. The cause of difference is partly because we removed more lymph nodes in robotic group, and we maintained lower complication rate in robotic group than on open surgery. Those two factors may have affected the difference outcome. However, currently many centers are more and more interested in the robotic esophagectomy after neoadjuvant CCRT. Asan Hospital is very famous for the neoadjuvant chemoradiation in esophageal cancer. They performed their initial series on the robotic esophagectomy after neoadjuvant CCRT, and they reported that vasopressor use of vasopressor was significantly reduced after robotic surgery. The authors explained about the phenomenon because robotic surgery reduced the tissue damage and minimized the inflammatory change after operation. So those findings can be related to the decreased vasopressor use. As a final topic, I will show the result of our hospital. We started the minimal invasive esophagectomy in 2006, and the first case was thoraco-laparoscopic esophagectomy, and we started the robotic program in 2008. In the mid-2000s, only 5 to 10% of patients received minimal invasive esophagectomy. However, currently, more than 95% of patients are receiving the minimal invasive esophagectomy, and the mainly robotic surgery now is being performed. And until now, we performed more than 400 cases of robotic esophagectomy. As you can expect, stage 1 and stage 2 was more than 70%, around 70%. So early stage is dominant in our patient population. So upfront surgery was done in 68% of patients. And however, we are doing the three-field lymph node dissection in advanced esophageal cancer, and 30% of patients received the three-field lymph node dissection. And in this paper, I want to show you the annual change of the mortality and complication parameters. As you can see in this paper, in this table, 30-day mortality and 90-day mortality did not change over the 10 years. And the 0.7% 30-day mortality was achieved, but the mortality was quite rare, so we cannot find any trend. However, respiratory complication rate is maintained steadily, around 10%. The improvement was identified in leakage rate. Leakage rate was significantly reduced after 2015. So after 2015, we are maintained around 5% leakage rate, which was very significantly improved since the previous periods. This is partly because of the improvement of technique in the graft formation, and partly because of the improvement of anastomosis technique, in my opinion. For long-term survival, in the upfront surgery group, the overall survival rate was 74%. It looks very good compared to previous paper. However, upfront surgery is performed only for the stage 1 and stage 2 disease. And in terms of pathologic stage, some patients shows upstaging. However, because we selected in early stage esophageal cancer, overall survival was quite favorable. However, we look at the neoadjuvant treatment group, the long-term survival, 5-year survival was just 51%, which was very similar to the previous paper. In this neoadjuvant treatment group, only stage 3 and stage 4 patients were included. So this is quite need some caution on the interpretation. because upfront surgery group looks like improved survival. However, neoadjuvant treatment group did not show any improvement even after robotic surgery. We need more study on this difference. So I must conclude my talk. In South Korea, minimal invasive esophagectomy is becoming more and more common, and the main technique is thoraco-laparoscopic or robotic esophagectomy. In the past, many hospitals in our country concentrated on early outcomes and did an operation in the patients with early esophageal cancer. However, many centers are focusing more and more on the long-term survival, and they are broadening their surgical indication for treating advanced esophageal cancer. But however, we still have many unknown questions on this issue. We need more studies on the minimal invasive surgery. Thank you for your attention.
Thank you for the nice presentation.